Hello, everybody. Thank you for joining us to our online lecture on diabetes. Due to the COVID infection, we have moved our lectures online. During this difficult and challenging period, I hope everybody stays safe. Together, we will get through it, and together, we'll get through this lecture. We will talk about the different types of diabetes and their classifications, as well as who to screen, when to screen, how to accurately diagnose diabetes. We'll talk about numerous options for treatment, how to prevent complications, and when they arise, how to address them, and then more on the prevention in terms of immunization, and finally, we will conclude our lecture. For a long time, diabetes has only been classified as type 1 or type 2. Type 2 being more common in adults who are obese. This is due to insulin resistance. There's plenty of insulin, our body just can't use it. Because the disease has an insidious onset and has been there for a long time, it is important that we screen for complications at the time of diagnosis. Type 1 diabetes is due to absolute insulin deficiency. It has a sudden onset, and a quarter of these patients will present with DKA. This disease is usually in children and adolescents. Because you're picking up the disease exactly when it started, we can wait to screen for complications up to 5 years after the diagnosis. The new classifications of diabetes includes latent autoimmune diabetes of adulthood. These patients will present just like type 2 diabetes, but they're thin, and then they quickly progress into insulin dependency. Maturity onset of diabetes of the young is hereditary and do not require insulin. Type 3C is due to beta cell destruction from repeated episodes of pancreatitis. They will require insulin. They're thin, however, they're also malnutritioned. Question number 1. Which is the correct recommendation for diabetes screening by USPSTF? A. Age greater than 45. B. Asian American with a BMI greater than 23. C. Age 40 to 70 who are overweight or obese. D. HDL less than 35. LDL greater than 250. The correct answer was C. USPSTF recommends screening age 40 to 70 who are overweight or obese. It is reasonable to screen every 3 years. However, high-risk groups should be screened earlier and more frequent. The most important recommendation is that these patients are referred to intensive behavior counseling, as lifestyle modification is key for diabetes control. American Diabetes Association recommends screening overweight patients, Asians with a BMI greater than 23. Asians have a higher risk of developing diabetes at lower BMIs. Additionally, they have to have one or more risk factors. First-degree relatives with diabetes, HDL less than 35, LDL greater than 250, insulin resistance or PCOS, physical inactivity. American Diabetes Association also recommends screening high-risk ethnic groups, with Native Americans being the highest risk for developing diabetes. For patients with prediabetes, impaired fasting glucose, or impaired glucose tolerance should be screened yearly. For women with a history of gestational diabetes, they need lifelong testing at least every 3 years. Other organizations actually recommend yearly screening. Patients who have coronary vascular disease, hypertension, or on medications for hypertension. All other patients should be screened at age 45. If you have normal results, screen every 3 years and more frequent depending on risk factors. There are several ways to diagnose diabetes. The standard still is to have a fasting blood sugar greater or equal to 126 on 2 separate occasions. You can also use a hemoglobin A1C greater or equal to 6.5. On a 2-hour GGT, a blood sugar of greater than 200 makes the diagnosis of diabetes. You can also use a random blood sugar greater than 200, but you have to have symptoms of hyperglycemia, such as polyuria, polyphagia, and unexplained weight loss. There's also some pitfalls in the diagnosis of diabetes. Point-of-care testing is not recommended. Certain conditions, like iron deficiency anemia, increase the lifespan of red blood cells. Small red blood cells are pumped out of the bone marrow, which stay around longer and get glycosylated, therefore falsely elevating hemoglobin A1C. Conditions like blood loss, hemolytic anemia, or hemoglobin variants decrease the lifespan of a red blood cell. In these conditions, you want to check fructosamine levels because this is an average sugar of 2 to 3 weeks versus hemoglobin A1C, which is an average sugar of 3 to 4 months. The physical exam on a diabetic patient is head to toe, fundoscopic, dental, neurologic, looking at the thyroid, cardiovascular, skin, and especially the foot. The patient should have their foot inspected at every visit. They should also be referred to podiatry on a yearly basis for monofilament, pulse, and vibratory sense examination. Similarly, they should see an ophthalmologist on a yearly basis. Laboratory workup includes hemoglobin A1C, panel 7, a lipid assessment, an EKG for baseline, and more importantly, a urine microalbumin. If this is abnormal, greater than 30, it needs to be repeated to confirm the diagnosis. If it is elevated, patients should be started on ACE inhibitors and ARB. If a patient is already on ACE inhibitor ARB, a urine microalbumin does not need to be tested, as they are already on the treatment. Lifestyle therapeutic changes are the cornerstone for diabetes management. Patients should consume a Mediterranean diet rich in monounsaturated fats. These have been proven to improve glycemic and lipid levels. Patients should consume no more than 10% of saturated fats. In addition, they should avoid trans fatty acids and unsaturated fats, as these increase LDL and lower HDL. The exercise recommendation is 150 minutes per week of moderate intensity, or 90 minutes per week of vigorous intensity. Exercise enhances insulin action on skeletal muscle up to a week following exercise. Structured exercise decreases hemoglobin A1C regardless of weight loss. Aerobic and resistant exercise together decrease A1C by 0.59%. In addition to lifestyle changes, most patients will require pharmacological treatment. We're lucky now that we have plenty of options. We will go through each class and decide when to use them, when to avoid them, and what benefits they may have for our patients. I have provided you a summary chart of all the different classes of oral medications, as well as their side effects, mechanism of action, and when to use them. Please feel free to use this for your studying purposes. Question number 2. What lab tests must you check before starting a patient on metformin? A. CBC, B. Urine microalbumin, C. Creatinine, D. Creatinine clearance. The first class we're going to talk about are insulin sensitizers. Metformin is the only one in this class. It works by increasing glucose uptake by target tissue such as liver, muscle, and fat. It also decreases hepatic gluconeogenesis. The benefit of metformin is that it does not cause hypoglycemia and therefore can be used in the elderly. Additionally, it causes loss of appetite and weight loss. It is commonly used in PCOS to increase ovulation, and it has a favorable effect on the lipid profile. The most common side effects are GI, such as nausea, vomiting, and diarrhea. These side effects usually subside within 1 to 2 weeks of starting the medication. Although very rare, lactic acidosis is the concern with metformin use. It is therefore recommended that a creatinine be checked prior to the use of metformin. In fact, metformin is the #1 choice for the treatment of diabetes. This is because it improves cardiovascular outcome, especially in overweight or newly diagnosed type 2 diabetics. It decreases mortality and it decreases major adverse cardiovascular events. It is the only oral medication that's approved in children and adolescents, and it is category B in pregnancy. The correct answer to question number 2 is to check creatinine prior to metformin use. Although we used to use an absolute creatinine number, it is now recommended that we use GFR instead. Metformin should not be started in patients whose GFR is less than 45. Caution should be used when patients have renal, cardiopulmonary, or liver dysfunction. Metformin should be stopped prior to IV contrast and 48 hours post-studies requiring contrast use. It is now also recommended that you check for B12 deficiency, as this is a common side effect of prolonged metformin use. You should feel comfortable using metformin. The dose is 500 mg or 850 mg. You can increase weekly or biweekly to a maximum dose of 2,550 mg, split in BID or TID dosing. You may not see clinical significant response if the dosing is less than 1,500 mg a day. To reduce the side effects of GI, mainly diarrhea, you can use extended release or take the metformin with meals. Metformin should be considered for patients who are pre-diabetic, BMI greater than 35, history of gestational diabetes, and PCOS. The American Diabetes Association actually recommends metformin in these patients to prevent the progression of diabetes. Metformin should be continued even if the patient is escalated to insulin treatment. This is because metformin has additive effects in the reduction of hemoglobin A1C with all other medications. Glutazones are also insulin sensitizers. They work very much like metformin by decreasing insulin resistance. They are second-line drugs and should only be used if metformin is contraindicated or unable to be tolerated by the patient. Pioglitazone has been shown to decrease stroke, MI, and death. It also prevents diabetes. However, their use is limited for this purpose as they have higher risk of bladder, pancreatic, and prostate cancer. Hypoglycemia is rare. Most common side effect is fluid retention and edema. For this reason, there's a black box warning for patients who have congestive heart failure with class 3 or 4 New York Heart Association. Classification: glutazones as a class also decrease bone density and increase fractures and should be avoided in patients with osteoporosis. They are category C. Question number 3. Which medication is safe in renal disease or renal failure? A. Metformin, B. Glyburide, C. Glipizide, D. Acarbose. Sulfonylureas are insulin secretagogues. They work by increasing insulin release from the pancreatic beta cells. As a class, they should be used in addition to metformin. The most common side effect is hypoglycemia, and therefore it should be used at low doses in the elderly. Glyburide has active metabolites that are renally excreted and should be avoided in renal dysfunction. The correct answer to question number 3 is C, glipizide. Meglitinides are also insulin secretagogues. The only difference is they have a rapid onset and are short-acting. This makes them amendable for patients with erratic eating habits. They can be taken 1 to 30 minutes before meals to control postprandial hyperglycemia. Most common side effect is hypoglycemia. Question number 4. How do you treat hypoglycemia with a patient on alpha-glucosidase inhibitors? A. Give patient a nectar or fruit. B. Glucose. C. Protein. Alpha-glucosidase inhibitors delay carbohydrate absorption in the gut. They're taken with meals to decrease postprandial hyperglycemia. There is no hypoglycemia unless they're taken with insulin or sulfonylureas. You must use glucose for the treatment of the hypoglycemia and not sucrose. This class of medication also inhibit the absorption of sucrose, which is found in fruits and nectars. The correct answer to question 4 is B, glucose. Question number 5. You have a 43-year-old female with type 2 diabetes, BMI of 45, who is on metformin at 1,000 milligrams BID. Her fasting blood sugar is 150 and her postprandial is 220. Her hemoglobin A1C is 8.5. Which of the following will improve her postprandial sugars and help with weight loss? A, liraglutide, B, pioglitazone, C, sitagliptin, D, nitiglonide. GLP-1 receptor agonists are also called incretin mimetics. They have a variety mechanism of action. In the pancreas, they potentiate insulin secretion. In the liver, they suppress postprandial glucagon secretion. In the stomach, they slow gastric emptying time. In the brain, they decrease appetite and increase satiety. Unique to this group of medications, they also have an action on the adipose tissue. They increase lipolysis. For this reason, this class of medications can be used in obese diabetic patients to help them lose weight. Liraglutide has actually been licensed for weight loss under the name Saxenda. It decreases visceral adipose tissue. A quarter of these patients will lose 10% of their body weight at 1 year. GLP-1 receptor agonists can be used in type 2 diabetics who are uncontrolled on maximum doses of 2 or more oral medications. You can decrease the hemoglobin A1C by an additional 0.8 to 2%. These medications should be avoided in patients with gastroparesis. Synthetic amylin analogs work similarly to GLP-1 receptor agonists by delaying gastric emptying, decreasing glucagon secretion. They can be used in type 1 and type 2 diabetics. Because they can cause severe hypoglycemia, it is important that you decrease the dose of insulin by at least 50%. DPP-4 is a natural enzyme that inactivates GLP-1. Therefore, DPP-4 inhibitors block the breakdown of GLP-1 and prolong its activity. GLP-1 then increases insulin release, inhibits glucagon release, lowering blood glucose levels. This class of medications is weight neutral. They can be used in monotherapy or combination. Hypoglycemia is rare, but they do have side effects for sore throat, URI, and pancreatitis. Disabling joint pain has also been one of the side effects. DPP-4 inhibitors do not have any outcomes data and offer a modest A1C lowering. SGLT2 inhibitors are the newest class of diabetic medication. Normally, 90% of glucose is reabsorbed at the proximal tubule with the help of SGLT2. This class of medication inhibit reabsorption of glucose in the kidney. They increase urinary glucose secretion. As renal function declines, they're less effective. They have a desirable side effect profile, which decreases weight, increases HDL, and decreases blood pressure. They have great outcomes data for decreasing risk of stroke, MI, and cardiovascular death. Unfortunately, they do predispose patients to euglycemic DKA and risk of foot amputations. Other side effects are risk of UTI and genital infections. Patients who present with euglycemic DKA tend to have normal or slightly elevated glucose levels, as well as ketones. Any patient who comes with nausea, vomiting, and malaise on this medication, you should consider the diagnosis of DKA. Here again is a summary of all the medications. Medications should be chosen based on their side effect profile, whether they cause hypoglycemia, weight gain versus weight loss, and which severe side effects you should avoid. When oral medication or combination of oral medications are not sufficient enough to control a patient's diabetes, you should consider adding insulin. If a patient presents with a hemoglobin A1C greater than 9, they should be started on insulin immediately. You can increase the dose of insulin until the blood sugar levels are at goal. Insulin decreases the progression to renal disease in type 1 diabetics, but not type 2. Patients have better outcomes when insulin is used early in the disease process. Insulin does not prevent cardiovascular events. It actually increases all-cause mortality, probably because of the more frequent hypoglycemic episodes. The bioavailability of insulin changes with the site of injection. It is faster in the abdomen and slower in the thigh. In athletes, exercise can accelerate absorption in the thigh and cause hypoglycemia. Injecting in the abdomen prevents exercise-induced hypoglycemia. Insulin comes in many different forms: rapid-acting, short-acting, and long-acting. Rapid-acting insulin, such as Lispro and Aspart, mimic prandial release of insulin. They are given with meals to control the 2-hour postprandial glucose levels that are high. Their onset is within 15 minutes, and their peak is about 30 minutes to 1 hour. Short-acting insulin is used for the same purpose, but has different onset and peak times. Long-acting insulins are used as a basal dose because of their prolonged duration of action. NPH is an intermediate-acting insulin, lasting 16 to 24 hours. Usually, 2/3 of the NPH is given in the morning, and 1/3 is given in the PM, around 10 p.m. at night. It can be used in all types of diabetes except for ketoacidosis or an emergency hyperglycemia. Long-acting insulin, such as Glargine and Dejamer, actually last 24 hours, unlike NPH. There's no peak, they have predictable control, and therefore are good in the elderly, especially the ones in long-term care. Degludec is a new ultra-long-acting insulin with action up to 42 hours. It has been noted that type 1 diabetics tend to have fewer hypoglycemic events on this insulin. In order to mimic natural physiology, you can use any of the long-acting insulins as a basal dose. Rapid-acting or short-acting insulin can then be used at breakfast, lunch, and supper. You should be familiar with the onset, peak, and duration of all the insulins. This is a summary chart to help you study. This is a sample of different insulin regimens. It is to help guide you when and what type of insulin to use to control blood sugars. For example, if a patient has high fasting blood sugars, you can add NPH at night. For patients with elevated postprandials, Humalog can be added pre-meals. For patients with elevated bedtime sugars, NPH can be added at lunch. Other delivery methods of insulin include inhaled insulin, which can be used in type 1 and type 2s, but not in patients with chronic lung disease or smokers. The insulin pump now is routinely used not only for type 1 diabetics, but also type 2, as it improves glucose control. The pump only uses short-acting insulin. There's a high patient satisfaction. Patients have to be motivated as it requires frequent blood sugar checks. However, now there's many models that have continuous glucose monitoring. It is important that you warn patients that weight gain is a common side effect of this pump. Lastly, pancreatic transplant is still experimental. In early diagnosis of type 1 diabetics, there is some hope that you can transplant stem cells to increase beta cell function. Now that we know how to treat diabetes, we will talk about prevention and treatment of complications, which include microvascular, macrovascular, ketoacidosis, hyperosmolar hyperglycemia, diabetic foot, and hypoglycemia. Microvascular complications include neuropathy, retinopathy, and nephropathy. Lyrica and Cymbalta are FDA approved and first-line treatment for neuropathy. Bicyclic antidepressants and SNRIs can also be used for neuropathy, as pain is modulated by serotonin and norepinephrine pathways in the CNS. The strongest predictor of retinopathy is duration of disease. The longer the patient has diabetes, the more disease you will find. Vitreous hemorrhage is the most common cause of monocular vision loss in diabetics. NSAIDs should be avoided in diabetes as they reduce renal blood flow and cause interstitial nephritis. Screening with urine microalbumin on a yearly basis is recommended. If abnormal, which is greater than 30, ACE inhibitors and ARBs should be prescribed to prevent nephropathy. The presence of urine microalbumin usually indicates coronary artery disease underlying. Macrovascular disease include heart disease, stroke, and peripheral vascular disease. All three can be prevented by having good glycemic control, blood pressure control, lipid control, and smoking cessation. 1% reduction in A1C equals to 21% reduction in complications. As stated earlier, intensive blood sugar control has long-term protection from cardiovascular disease in type 1 diabetics, but not type 2. There are increased recommendations to have a blood pressure goal of 120/80. High-dose statins are now recommended for all atherosclerotic cardiovascular disease. Statins do increase new onset diabetes by 9%. The number needed to harm is 1 out of 498 versus the number needed to treat is 1 out of 155 for cardiovascular events. Because their benefits outweigh the risk, all patients should be on high-dose statins. Encourage all patients to stop smoking, as smoking by itself increases the risk of developing diabetes and atherosclerotic cardiovascular disease. Aspirin is recommended for both primary prevention and secondary prevention. USPSTF recommends adults age 50 to 59 with greater than 10% 10-year cardiovascular risk to be on aspirin. This essentially includes males greater than 50, female greater than 60, with one additional risk factor, such as smoking, hypertension, family history of premature death, dyslipidemia, and albuminuria. For patients with known cardiovascular disease or symptomatic peripheral vascular disease, they should be on aspirin or Plavix for secondary prevention. Question number 6. A 19-year-old G1P0 at 38 weeks with poorly controlled type 1 diabetes and ketoacidosis presents in active labor. Glucose is 670, pH 7.12, potassium 6.8, sodium 130. Treatment with IV fluids and insulin is given. 3 hours later, glucose is 310, pH is 7.25, potassium is 3.3. What is the most appropriate next step? A. Start glucose. B. Start insulin. C. Add sodium bicarb. D. Continuous IV fluids and replacement of potassium. Diabetic ketoacidosis is usually in type 1 diabetics. It's uncommon in type 2 unless they're Hispanic or African American. Risk factors include infection, surgery, medical noncompliance, or MI. These patients will present with abdominal pain, vomiting, Kussmaul's respirations, which are deep, rapid breaths, a fruity breath odor, and in severe cases, coma. The diagnosis is based on high blood sugar, usually greater than 250, a high anion gap metabolic acidosis, with ketones present in the serum and in the urine. Volume replacement is the most important thing to do first. They usually have a 5 to 8 liter deficit. You can use 1 liter normal saline bolus per hour to correct the dehydration as fast as possible. An insulin drip is started and continued until the anion gap is closed and glucose normalizes. When the blood sugar drops to less than 250, you can add D5 and reduce the insulin. The potassium level is falsely elevated due to the acidosis, so you should start replacement when potassium is between 4 and 4.5. If the potassium level is less than 3.3, you must replace potassium prior to starting insulin. Insulin causes an intracellular shift of potassium and causes worsening hypokalemia that can be fatal. The answer to question 6 is D. continue IV fluids, and replace potassium for this reason. Bicarb is only given for severe acidosis when the pH is less than 7.2. Hyperosmolar hyperglycemic coma or non-ketotic hyperglycemia is usually in type 2 diabetics. As the name indicates, there's hyperglycemia, usually greater than 800. It is a hyperosmolar state without ketosis. The risk factors are the same as DKA, but this carries a higher mortality rate. Patients will present with confusion, lethargy, and coma, which usually resolves with the correction of the acidosis. Treatment includes treating the underlying stresses, IV fluids, insulin drip, replacement of potassium, and an insulin infusion. Oral or sub-Q insulins are not adequate. Question number 7. Which oral diabetic medication can cause euglycemic DKA? A. GLP-1 agonist. B. DPP-4 inhibitor. C. SGLT2 inhibitor. D. Alpha-glucosidase inhibitor. The correct answer is C. SGLT2 inhibitors. Remember, this class of medication increases urinary glucose excretion. The serum glucose can be normal or moderately elevated. However, the presence of ketones and acidosis should lead you to think of DKA. Any patient on SGLT2 inhibitors who presents with nausea, vomiting, and malaise, the diagnosis of euglycemic DKA should be considered. The most important exam you can do on a diabetic patient is to look at their feet at every single visit. Diabetes is the leading cause of non-traumatic foot amputation. Due to the neuropathy and vasculopathy, patients can go from a wound infection to ulcer and to osteomyelitis very quickly. The monofilament test is the best test for sensation and the best predictor of future ulcers. Having a pulse, which indicates intact vascular supply, is the best indicator for successful healing. For treating ulcers, it is important that we have aggressive prevention, remove pressure, wound care, and debridement. For new untreated infections, you should cover for gram-positive staph and beta hemolytic strep. If patient was previously treated, it is usually polymicrobial, and you should cover MRSA. If osteomyelitis is suspected, the best test is an MRI. Hypoglycemia is a common side effect of almost all the medication regimens we discussed, except for insulin sensitizers. Patients should be educated about symptoms of hypoglycemia, which include palpitation, sweating, feeling lightheaded or dizzy. In severe cases, patients can present with confusion, stupor, or coma. Glucose tablets can be used to treat hypoglycemia in a conscious patient. If they are unconscious, you can use glucagon 1 mg IM or 50% glucose IV. What hemoglobin A1C goal are we treating for? This depends on the duration of disease and the life expectancy of a patient. Generally speaking, in young patients who have a long life expectancy, a hemoglobin less than 7 is desirable. For older patients with disease duration of greater than 10 years, a hemoglobin of 7.5 to 8% is acceptable. Intensive glucose control has no effect on cardiovascular outcome. Additionally, it may increase the risk of mortality with long-standing diabetes and risk factors for cardiovascular disease. The A1C goal should be individualized. All diabetic patients should have the following immunizations: influenza on a yearly basis, pneumococcal at the time of diagnosis and then repeated at age 65, and there must be 5 years apart between those two doses. PCV13 also at age 65 unless they have chronic renal failure, and then it can be given earlier. Hepatitis B, Tdap, and zoster at age 60. In conclusion, patients who are overweight or obese between age 40 to 70 should be screened for diabetes. The standard for diagnosis is a fasting blood sugar greater or equal to 126 on 2 separate occasions. Diet and exercise should be part of the treatment regimen. Metformin is the first-line treatment. Other oral medications can be used in combination with metformin. If diabetes cannot be controlled on oral medication, then insulin should be added. Aspirin is used for both primary and secondary prevention. Vaccines should be offered and given on a timely basis. The goal hemoglobin A1C is less than 7, but needs to be individualized. Blood pressure control, lipid control, and smoking cessation are equally as important in preventing complications.